Hello everybody and welcome to this latest episode of Cardiomyopathy Conversations. It's Libby here and I'm delighted today to be joined by Professor Ruth Newbury-Ecob, clinical geneticist, and Professor Perry Elliott, consultant cardiologist. Perry, if we think about your clinic, okay, you've got a new patient coming in, they come to your clinic, they've been diagnosed with a cardiomyopathy, let's say at their local hospital. At what point in that consultation do you raise the subject or the concept of genetic testing? At what point does it become, how do you know when to raise it or if to raise it? Is it always relevant?
So I think I do it pretty much every time.
Okay.
As part of, I mean, it's almost stereotypic because I think by the time people get to us, they're coming for confirmation of diagnosis, for risk stratification, maybe determination of the underlying cause. But for me, that's just part of the narrative from this is what you have, this is what it may or may not do to you. I think you're at high or low risk. What are the potential causes of this? Well, the potential causes are X, Y, and Z. And genetic testing may help us in understanding the diagnosis or managing you. But we wouldn't necessarily do genetic testing at that first consult because what I've just said is a synthesis of a lot of information, a lot of implications. Some people come actually wanting or expecting to be genetically tested, whereas others need to really go away, think about the implications. So I may do it on the second or even third consultation. Yeah,
that kind of brings me on to my next question, which is about the genetic counsellor side of things. So does everybody see a genetic counsellor? Or, I mean, I know you said before that you sort of do a bit of that counselling in your consult.
So I think we tend internally to refer to a genetic counsellor when we start the process of genetic testing.
Okay.
But I think everybody in the team does some genetic counselling.
Yeah.
With different emphasis, with reinforcement of knowledge. But if we're dealing with a genetic disease, just by talking about that disease and its cause, you're effectively counselling.
Yeah. Yeah, we refer to genetics much later. We have a trained cardiac nurses to be involved in that early discussion and cardiologists to undertake the testing themselves.
Wow.
There are some families where it's appropriate to refer straight into genetics, particularly if it's already known that within the family that there's a gene. But if this is the first patient presenting in the family, often the initial discussion and arranging testing is done in cardiology. That's quite a big change that comes from the top. We call this mainstreaming. It's really designed to speed up the process.
Yeah.
A lot of patients will tell you they have waited years
and years,
because their services are tiny. And so this is a big leap forward in making testing more accessible for it to be offered in cardiology.
You may have answered my next question, which is why, I know the pair of you. Why would somebody come to see you, a clinical geneticist, rather than somebody like Perry? What's the difference there between, why would they make that? Why would you make that decision to refer to you?
Absolutely no idea, Libby.
Maybe it's
if I could see Perry, I wouldn't come and see me. There's lots of layers.
Is it about how services are set up?
It can be about how services are set up. So in certain areas, all genetic testing is done, and it's very centralised around genetics. In some, it's quite the opposite. I think it depends. We work very much, and I think Perry as well, in what we call a multidisciplinary team approach. So we're all actively involved in cases, but we might not actually be seeing them. So very few people would come to my clinic, but I might be overseeing those cases through the multidisciplinary team and supervising the genetic counsellors and cardiac nurses who are looking after their families. What I won't dabble in is therapeutics, cardiac management, lifestyle advice, any of that. That's very much Perry's domain. I think for some people, and particularly around the patients who are requesting testing who are asymptomatic and clear of screening, I think many of those patients see a genetic counsellor to explore the complexities of having a test in that situation, which is slightly different. Some people use the word predictive testing, but we're talking about people who are healthy and well, no evidence of the disease, but they're interested in finding out perhaps for wider family reasons or their future. And I think that's where genetics has a more of a role. Sometimes I think stepping out and stepping away from the therapeutic environment, interesting patients. Some patients like everything to be done in a one-stop shop sort of way, but for some, I think stepping out of that and really talking about the wider issues of genetics, having a very detailed explanation of genetics, really, exploring that. That's where the added kind of value comes.
Okay. And I think, you touched on this earlier, but I always think when you test for genes, you use the panels, test gene panels. Is that not the case anymore? Do you now actually routinely do the whole genome sequencing?
No, we're still using
You're still panels?
Yeah.
Okay. Talk to us a little bit about those panels. How do they work?
So because any gene testing produces lots of variants, so when the laboratory do a genetic test, they're looking for changes in the DNA sequence, and there will be many. If they are processing a sample on a patient who has a cardiomyopathy, they really want to just focus on those genes that are likely to cause cardiomyopathy. They don't want to be looking at the genes for diabetes and everything else. So it's called a targeted panel. It's targeted towards a specific condition. And within the cardiomyopathy testing, it's more specific than that. There are panels for hypertrophic cardiomyopathy, for dilated cardiomyopathy, for pediatric cardiomyopathy, for arrhythmogenic cardiomyopathy. And it just means that there isn't a lot of additional unnecessary work looking at genes that aren't relevant. It's focused around the genes that are most relevant.
This might be a really stupid question, okay? Might be. If you have panels that are specific to hypertrophic or dilated, is it even possible to have hypertrophic and dilated cardiomyopathy? And if you're only testing for one panel, would you miss the other one? Is that a stupid question, or is it
not a stupid question at all? And I think there would be some merit. I think there are people who think that targeting panels is too restrictive.
Yeah.
But actually, you just say this is heart muscle disease. We look at everything that causes heart muscle disease, and I would be one of the people that would support that.
Okay.
I think some of these distinctions are a little bit artificial.
Right.
And but I think when the panels are listed on something we call the test directory, and this is taking into account that this is an NHS service. It has to be standardised. So there are 4 laboratories that offer cardiac genetic testing in the UK. And it's really important that whether you're tested in Sheffield or Bristol
you get
or
the same
London,
result.
you will get the same result. And that is much more likely if you work within some well-defined, agreed parameters. So it's probably the difference between offering a service that is realistic and research, which would be much more casting the net.
Yeah, I think that's... So your point about can you have HCM or DCM, I wouldn't say you can have HCM or DCM, but you can have genes which cause both conditions. And the rare situation, is it such a rare situation to inherit more than one monogenic? It's not.
No, not at all.
So if you the narrower your focus, the less likely is you're going to detect the fact that this person has a cardiomyopathy gene, but maybe they've also got a gene which predisposes them to arrhythmia, like a long QT gene, for example. So I think there is an intrinsic danger in being too narrow in the diagnostic panel. I think the other problem is that and this is where the fuzzy bit between research and clinical service, because you have to be pragmatic about a clinical service provision. But the danger is you fossilize things. Mm. You say, this is the truth, so we won't test for these genes because we don't think it causes this particular clinical picture. But then you're never going to know if it does without testing. Mm. So I like the potential of a whole genome, so it's there. It's how you engineer a flexible discussion with a lab. And I think that dialogue with a lab is really important because the result might come back and you say, well, this doesn't make sense to what I'm seeing here in the clinic or in the family. You've told me they've got a variant in this gene. Well, that doesn't fit. But that knowledge and skill of knowing when it doesn't fit that's a really hard one to teach and to grow. Yeah. But it's fundamental. Interpretation of genetic variants is not just about the sequence variant, it's about what it looks like in the individual and their family.
Yeah. Which is why this, multidisciplinary approach with cardiology, clinical genetics, laboratory genetics. We have electrophysiologists, academics who can test these variants out as well. It really is pooling lots of knowledge to make sense of this. I just snip in with the 100,000 Genomes Project, which is another UK world-beating. The individuals within that project who were recruited with cardiomyopathy, some of them were tested on panels and got some answers. Many of them weren't, but they form a cohort of patients where researchers can look for new variants, new genes. Yeah, exactly that. Makes sense. Did we do the right panel when we did this one? Should we have done a different panel or an extended panel? And looking wider.
It's how knowledge about new genes emerges. You have a data set and you say, hang on, we've seen this again, maybe in a gene elusive situation. And this gene keeps coming up. So then proving that that's causative is tricky sometimes. But you only know that it's a potential disease gene because you've seen the recurrent signal.
Yeah. So if we go back to your clinic, Perry, when that test is done, when the genetic test is done, I say this advisedly, you either come out with a positive or a negative, which I probably, or maybe not. For the purposes of this question, let's just assume it's positive or negative. What's the next step for you then in the clinic with the family in terms of how they relay that information to the family? Does the cardiologist get involved in that side of things? Is it up to the patient? Is there support for people to do that? How does it work once you've got that knowledge?
This is new diagnosis rather than someone within the family getting a positive.
Yes.
So if it's a new diagnosis, then the initial transmission of information is usually through our genetic counsellors, but then we would bring them up to have a discussion with a cardiologist to explain again what that means for that individual and what it might mean for their family. There's then that difficult process of being able to cascade that information to the rest of the family so that other individuals can go to their GP and be referred in for predictive testing. And at the moment, our system puts the onus very much on the index case in whom you've made the diagnosis. So we can help that process. We can give them letters saying what their diagnosis is, saying what the genetic variant is. Please hand this out to your relatives so they can then take it to their GP and be referred in. And that it works to an extent, but I wouldn't say it's a perfect system.
No.
I mean,
how do those people come back into the system anyway? So let's say I get get presented with a letter and it says, look, we've got this in the family, and I think, so I should probably go and get tested. How do I then?
GP.
Okay.
You take the letter to your GP and it'll either say, if there's a genetic variant, it may well say, first make contact with genetics. Actually, we tend very much to say go to cardiology.
Okay.
Because actually the waits are shorter, but also the echo is often the most important thing because that has implications for your health and well-being. The genetic testing is important, but you really need to know whether you have this condition. Start with cardiology, and we have contacts who are specifically trained ICC cardiologists, so we would make a suggestion that your GP refers you. In fact, we accept self-referrals as well.
Oh, do you?
Do
Yes,
you?
we do.
Ah.
Yes, we do.
Okay.
Yeah.
Do you?
Not officially.
Oh, okay. On the quiet with a bottle of whiskey.
Well, no, I suppose the fear is that you open the floodgates, but but actually probably a self-referral is certainly as good, maybe sometimes better than
For first-degree relatives
Yeah.
only. So it is only first-degree relatives, not second-degree.
Mm-hmm.
Yeah.
That's the tricky thing, is somebody has heard that uncle or aunt, more distant, and then we have. That's where I think genetics often gets involved in trying to establish, who has the condition, who has had a gene test, is there a genetic test recorded that could be used, where is that, who has access to that information, etc., etc.
It's one of those things that on the face of it you think it could actually be quite straightforward, but if you scratch the surface, it really is quite far-reaching, isn't it?
It's also the problem of the inability to transfer information within the system.
Yeah.
Sometimes for example, data protection issues. Sometimes just simply because of the lack of an IT infrastructure which allows you to transfer that information. So it's not infrequent. In fact, it's probably usual that we get a referral. Someone will bring their letter. Uncle Fred has got hypertrophic cardiomyopathy. I've received this letter from Uncle Fred saying I should come for screening. That's all the information you have. So does Uncle Fred have a cardiomyopathy? Is it hypertrophic? Are we sure it's hypertrophic?
Yeah.
What is it, even the variant? What is the variant? So you then have this huge paper trail where whether it's a counsellor or a genetic nurse, they have to bring that information together with the consent of multiple individuals, because you can't just access that information.
No.
It has to be consent. So it does take a long time to bring in information on a family.
Yeah, I think a lot of genetic departments are working towards having family history coordinators.
Oh, really?
And their job is to assemble that information.
Right.
And if we compare it with the familial cancer work, before the referral is accepted, there's a questionnaire that goes out that collates this information and also asks for permission to access the records.
Do you ask for consent?
We do. We do ask for consent. So if the letter has been shared by the person, that will be clear from the letter. Then we don't need to seek their permission because they have passed that letter on.
Yeah.
But if they haven't, yes, we do.
Yeah. I think one of the quite complex areas where that could be an issue for patients when they discover that they have or they're carrying a variant is in terms of decisions around family planning and whether they will pass that variant on to potential children. Are there any options for people who are in that situation? What could they do? Is there anything that could be done?
Yeah. So for either a woman who has a cardiomyopathy, who's having a pregnancy, wants to have a pregnancy, or whose partner has cardiomyopathy, those are couples that we would often offer genetic counselling to.
Okay.
So it'd be very reasonable to request genetic counselling in that situation. And then they would talk through the options for both management of the pregnancy, so referring on to discuss with the relevant obstetrician and cardiologist, is this a reasonable thing to do? But we'll also talk about any tests that can be done in the pregnancy. And that includes tests that are genetic tests, but also whether or not fetal echoes should be done. And a plan is constructed. So in terms of genetic testing options, there are a number. One involves a workup pre-pregnancy where you know what the genotype is. We can look at fetal DNA in the maternal blood. Then we have tests that at 10, 11, 12 weeks, which is the test to see whether or not the fetus carries that same gene.
Mm-hmm.
That can be done later using amniocentesis.
Okay.
And also in some families that fulfill certain criteria, the testing is done linked to IVF.
Yeah.
With selection of embryos that are known to be unaffected.
Mm.
So the embryos are harvested through a normal IVF program, but allowing for testing to show whether or not the gene is there. And particularly for the more severe cardiomyopathies with early age of onset, that's something that's available, but it's on a family case-by-case basis. It takes quite a bit of workup, and it's linked, as I say, to the IVF criteria as well.
Is this something, Perry, that you consider when you see patients in your clinic about that sort of ongoing planning of, family and life?
I think as Ruth laid out, I mean, it's the pre-implantation genetic testing element, but it's the whole thing. So you're now a family with a disease that can be transmitted, and so that has implications for the offspring. If one of the parents, if the mother particularly, is affected, what are the implications for her? Should she conceive and want to go through a normal pregnancy? So you, as part of this multidisciplinary team, you also need cardiovascular obstetric teams who are used to managing that kind of advice as well. Ideally, giving that advice before someone conceives. Many of the drugs we use in cardiomyopathy, for example, are potentially toxic to a fetus. So you're trying to give people the knowledge they need to be able to avoid complications of pregnancy. It's that sort of maternal health element, if you like, to familial disease, to genetic disease.
We also make a plan if there isn't testing undertaken during the pregnancy of follow-up of the baby.
Yeah.
So decisions around referring them in at an early stage to paediatric cardiology, who can set up an appropriate screening program and have discussions at an appropriate time about testing.
Do you ever find that people in the moment don't really want to know about that, but then further down the line they might pick up again? How do they sort of get back into the system again if they originally said, no, I don't want to go down that route?
We have patient-initiated follow-up, and I think we have PIFU, and I think because that is a very reasonable. Nobody knows how they're going to feel about these situations until they're there. So we would always give the information. You decide where you want to go with this. If you change your mind, you come back to us.
Do you ever come up against the sort of ethical questions around that, about literally, removing parts of their sort of genetic makeup, and there's an ethical question around that, isn't there?
Around PGT,
testing embryos. Testing,
Yes, but I think that's the discussion that's happened elsewhere with the HFEA that is regulated.
Okay.
And I think if the technology is available, our role is to tell patients what's available and let them make choices. In the UK, this is all very, very regulated.
Okay.
So only a certain number of centres are able to offer this. They have to be able to show that the testing is accurate. And long-term studies of PGD has been now around for many years. Many, many babies born worldwide, and very good follow-up studies that show that this is not harmful in any way.
And just thinking about sort of genetic therapies, I'm going to ask you this one, Perry. So, in terms of things like gene silencing, gene replacement, gene editing, which is a little bit of what we've just been talking about, is this all is it still in the lab? Is it still science fiction? Or is it becoming more and more like a realistic treatment option for people?
I don't know, because you've listed 4 very different approaches to managing genetic disease. They're all very different. Many of them are still very experimental.
Yeah.
So what we're talking about is doing something about that genetic spelling mistake to prevent it from manifesting as disease, or in someone with the disease is to sort of turn off the bad gene, if you like, so the disease doesn't progress or perhaps even the disease regresses. And there are different ways of doing that. The one that's now which is happening now, is what we call gene replacement. So if you have a spelling mistake which results in a particular protein inside the heart not being made, the idea is, well, if we put another normal copy of that gene into the cell to produce that missing protein, we can restore normal function to the cell. The problem is how you get that gene into the cell.
Yeah.
And so you need you need what we call a vector. You need something which transmits that normal gene to the heart tissue.
Yeah.
And at the moment, what's being used are safe viruses, if you like, viruses called adenoviruses, which are inert viruses, so there's no risk of transmission of those viruses. You package up the gene inside the virus, inject that virus into the body, it then travels around and delivers it into the heart tissue. There's lots of problems, lots of challenges. Just by doing that, you can fire up the immune system.
Yeah.
So gene replacement therapy now requires pretty industrial immunosuppression to prevent that from happening. We don't know, or the heart is very resistant to taking things up. So you can inject viruses into the circulation, but the majority of them won't make it to the heart. So
what happens to them?
They'll get smashed up somewhere else, or they activate the immune system. So we've tried different approaches, or people have tried different approaches, direct injection down the coronaries. None of these things seem to be any better than injecting into a vein peripherally.
Okay.
But sometimes you have to give such a high dose peripherally that reduces the safety of the technique. It makes it much more likely you're going to stimulate the immune system. So this has been done for hypertrophic cardiomyopathy. So there's a trial which has begun in the US around a gene called myosin-binding protein C. We're waiting to see the long-term results of that. There's another trial which is starting, which will be participating in a couple of centres in the UK around a gene called PKP2, which is a gene which causes arrhythmogenic right ventricular cardiomyopathy. We'll see. In fact, what I often say is the biggest challenge for gene therapy is we don't know what it's capable of. Because it ain't cheap. So gene therapy is going to be millions per patient.
I feel like we've had this conversation before, though, about the cost of therapies and the mindset around whether society or companies feel it's valuable.
Yeah. And as you say, we've discussed, so I feel very strongly that we have a particular mindset in cardiovascular medicine that all pills have to be cheap. But this is a whole other order. So, are we going to give a therapy which costs $3 million to change a particular marker in the blood by 10%? I don't think we're going to do that. So we've got to show, I think, a pretty dramatic effect, which is beneficial to the patient in the short to long and medium, short long term. But there may be other ways of doing this, which there's not this complicated immunosuppression, giving viruses. So some of the other things you were talking about, so things like RNA editing, for example. So rather than going to the gene, you go to what it does downstream, and you can alter that. So sometimes just by turning it off, you'll get a benefit. Sometimes by skipping the spelling mistake in the gene, you can produce a protein which isn't quite like the original one, but enough to be functional. Gene editing is the real science fiction, isn't it? Where you actually go to the genetic code
and cut it out
and correct it. And that has been, it's sort of been done. It's been done in amyloidosis, for example. But that's challenging. Again, delivery, how do you get it to the heart? And then you're also then starting to open up an ethical box where altering genetic code in some cultures, in some societies, is a little tricky.
Yeah.
And I think, society expresses its concerns about it as, what does the effect of editing one gene have on the other genes? Are you actually replacing one disease with another disease?
Yes.
These things are quite hard to evaluate. You might need very long studies.
That's interesting, isn't it? I hadn't thought of that, that actually you think you're cutting out the bad bit and everything will be okay, but actually by cutting out the bad bit, you might be causing other issues in other
You
genes.
might be a little bit off target. You might be doing things that you hadn't anticipated.
Yeah.
Genes are multifunctional. They do different things at different times in different places. So you want to only get the ones that are working on the heart. Yeah.
Again,
Quite
complex.
Complex. Yeah.
It's really complex.
I think it's. I don't want to preempt your question,
No.
but I always asked about gene therapy, and I'll say very little. What I say is I think the direction of travel is pharmacogenetics and targeted therapies.
Yeah, I agree. And you don't necessarily have to go for the gene. You can go downstream to what the gene is doing biochemically further down the line. And that's we have some very successful examples of that now in hypertrophic cardiomyopathy, for example, a drug called mavacamten, which was designed on an understanding of the molecular consequences of gene variation. But it's not doing anything to the genetic code. It's dealing with the biochemical consequences of that genetic variation.
Of course, you have preempted a question. We'll come back to it. So my sort of penultimate question is really, I think it's one for you, Perry. As the sort of genetic diagnosis becomes more and more at the forefront of cardiomyopathies, do you think that there will come a time where cardiomyopathies will be classified by the gene? So you won't say that somebody's got dilated cardiomyopathy, you'll say they have titin cardiomyopathy or a lamin cardiomyopathy. Is that a realistic proposition, and what impact do you think that will have on patients?
So I think it's already happening.
Right.
So we use those terms, laminopathy or dystrophinopathy. Some of the gene names make it very difficult to turn it into an opathy. But so I think we're already there to some extent.
Right.
I think we've also I've made a career out of that classification process, but the classification process has become more complex. And so I think our diagnosis, at least for me, I talk about this concept of a narrative diagnosis. To say someone has HCM or DCM is so high level, it doesn't really help you. It doesn't help you in understanding the disease severity, how it's affecting the individual, what the underlying cause is. So it's the beginning of a story. So for me, it's more about saying this person has left ventricular hypertrophy with normal systolic function, an outflow tract gradient. It's caused by a variant in the myosin heavy chain gene, blah, blah, blah. That's the diagnosis.
Do you think that's reaching patients, though? Because people will still say, oh, I've got HOCM.
Yeah.
Or I've got DCM, you know.
I think it's a bit like the word mutation. I think it's a useful, shorthand.
Yeah.
But I think the danger, or what we've seen in medicine, is that those shorthands result in, I think, sometimes inappropriate management or misunderstanding about pathophysiology of disease or genetics. Just saying something as HCM or DCM or ALVC, I think it lacks the granularity you need to be able to make a management plan for that individual, their family, and so on.
Do you see this like in the same way as you might get a cancer diagnosis? You might say, I have, breast cancer, but actually beneath that,
absolutely,
there are layers of, information that absolutely affect how that cancer is treated.
Very much so.
Yeah.
And
you
also
see it going the same
affects the information for families that, how we discuss testing and when we do testing, the ages at which we do testing do reflect those subtypes. So we are very proactive about the types that are linked to arrhythmias, and we would be more active in encouraging testing and at an earlier age, probably, because we know it's going to have bigger implications. So it's very helpful for us as geneticists in working out those, who should be tested and when, to have that additional information. I don't think we know, because we don't have good registers of disease, how many patients have had genetic testing, but we strongly suspect there are still large numbers of families who haven't.
Right.
And
so they will still be classified as DCM and HCM.
It's incredible, that, isn't it? So, we've got some things really right in our processes in the UK. So the whole concept of the 100,000 genome, we have a national testing service which many countries don't have. It's free at the point of use. So, so it may have certain restrictions, But if you're sitting in a hospital clinic, you can get the sample sent off. You're not having to persuade your hospital to pay a huge amount of money for that. But we don't have basic information about the number of tests that are being done, where they're being done, how many families have been tested, what the denominators are. It's a missing piece of information.
How would you go about getting that?
So we're talking about that now. So we actually have very good electronic health records in the UK, but they're good for hospital records. So when a patient comes through the door of a hospital, they're coded, there's stuff recorded. But if you go to an outpatient clinic, there's no coding of your disease. So we're trying to find a simple way which doesn't burden individuals in the clinic. Because if you go to a cardiologist or a clinical nurse specialist and say, we want you to spend an extra half an hour filling in this database on every patient you see, it ain't going to happen.
No.
I think it's as simple as just saying that before you go out through the door, you put the code in, what is the diagnosis? So at least just to start with a national picture of how many people there are with a diagnosis of hypertrophic dilated, and then iterate that. Have you had a genetic test? That's the second question. Sort of thing.
And primary care.
Primary care, yes. Elaborate.
I suspect there are patients who have this stamped on their records in primary care.
Yes.
And get repeat prescriptions. And do
they
they?
do. I mean, we have looked at GP records. I think there are certain anomalous. If you believe the GP record, 30% of people with a diagnosis of hypertrophic cardiomyopathy have never been referred into a cardiac service. Now, that may be true. It may be true. Or it may be they've been in hospital and a coder has, for some reason, said they have HCM, and they may or may not actually have HCM.
Yeah.
So I think we're getting there slowly, but in order to be able to plan services, to determine the inequalities which almost certainly exist in terms of access to testing and to evaluation, we need proper national data.
We still do a lot of diagnosis. Somebody's referred in the family, and actually it's clear from when you take the family history, there are strongly suggestive symptoms, diagnoses that point to the fact that somebody did have a cardiomyopathy, but it was never named. And I think that, I'll leave it to you to go into heart failure clinic overlap. But
also if somebody's got like left ventricular hypertrophy on their notes, but that's not specifically cardiomyopathy, but it could be.
Could be, yeah.
My final question. So imagine 10 years from now, we're all retired. Perry's writing his memoirs. What do you think the cardiomyopathy scene is going to look like in 10 years' time? Are we going to see everybody with genetic therapies? Are we going to be further down the road with things like mavacamten? What do you think it's going to look like a decade from now?
I think the future is bright. I mean, the last 5 years have been... so I've been doing cardiomyopathies for 30 years, probably. And the last 5 years have been very different to what came before. So some of the stuff is the same in terms of phenotyping, taking family histories, genetic testing, etc. But we are now starting to think about disease modification, treatment. We even had a discussion earlier about cure.
Yes.
So we have new drugs coming in for hypertrophic cardiomyopathy. Already we're looking at second generations of those particular compounds. There are new compounds coming along. Companies are now focusing within the heart failure paradigm. One of my big things is I hate this HFpEF thing.
Yeah, I know, yeah.
But it's very clear that the pharma industry is moving away from that very simplistic approach to describing heart muscle dysfunction, realizing that people with variants in one particular gene don't necessarily respond in the same way to conventional therapies, let alone emerging therapies. So I think we're going to have a much more bespoke approach to therapy. I think there are certain challenges that we're going to also face as a consequence of that, because I think the diagnosis is becoming more frequent. So we have to think about the service models. We have to think about how we train staff. I think that the time has come to recognise inherited cardiovascular disease as a subspecialty in its own right, with its own need for training standards, for investment, for national organisation, hub and spoke models. There's a lot of things that need to happen for us to deliver those potential benefits, which I think are huge, to everybody who may benefit from them. So I think it's bright, with a lot of work to be done still.
Bright but hard work.
Yeah.
And Ruth?
I think that because we can do testing, I think more people will have genetic testing, and I think in 10 years, hopefully, everybody will have genetic testing. It also means we're going to have people who were tested 10, 20 years ago, and I think early interventions, I hope, are going to be worthwhile. I mean, that's one of the reasons for doing testing, to hope that screening and early therapies will make a difference. So improving the outlook for patients with cardiomyopathy, built alongside, I think more targeted therapies and pharmacogenetics. I think that's a wonderful area for investment. We've seen some extraordinary examples of that in other diseases where they may not be curative. You need to continue with your therapy, but they have really profoundly changed disease management, and that isn't gene therapy. That is, as Perry said, the targets. What is this gene doing? So I think those are really, really positive steps forward. And I think this is a condition that is worth knowing about. We have people who don't want to have genetic testing. That's fine. That's their choice. But I think what we're able to show them now is there's value in having genetic testing, because it means you can access these treatments, preventative measures.
It's very exciting. Thank you so much, both of you, for having a conversation with me today. It's been really fascinating, and it's been lovely talking to you both.
Thank you.
Thanks.